I'll quickly just introduce everyone. Well, introduce the webinar and itself. I think we'll get going now. So yeah, just to say welcome to all the participants and so everybody that's joined this kind of important webinar. We're looking at COVID-19 and its impacts upon all the ethnic minority groups and some of the disproportionate impacts that we've seen there. I mean, my name is Matt Johnson. I'm a research associate based at the Runnymede Trust. And just to say, I'm just genuinely excited about the discussion that we're about to have here today, this afternoon. I mean, these webinars are actually less of a webinar and they're intended to be more of a conversation. So please do feel free to join in the conversation by posting your comments, your thoughts, your questions. And I also just want to say that it's our pleasure to work with the Center on the Dynamics of Ethnicity code from the University of Manchester on these webinars and to pull these together. At this stage, it kind of gives me great pleasure to introduce our chair for the afternoon, Dr. Dami Kapadia, who is also one of the key members of CODE at the University of Manchester. She's undertaken really important work, research work, looking at ethnic inequalities and issues such as social networks in poverty. And she's also co-authored the briefing that was accompanied with the invite to this webinar that underlies this study, along with Dr. Jenny Hewitt, entitled Ethnic Minority Older People, Histories of Structural Racism and the COVID-19 Pandemic. So I'll just hand over to Dami now, who will also introduce our panelists as well.
Good afternoon, everyone, and thanks very much to Matt for the introduction. So I just want to say thank you to the Runnymede Trust for partnering with us at the Centre on Dynamics of Ethnicity, or CODE, on these briefings. And the briefing we'll discuss today is the latest in the COVID briefing series, and they are all available on the Runnymede or the CODE website. So please do check those out and have a look at our other work as well. So as Matt said, the briefing that forms the basis for this webinar is called Ethnic Minority Older People, Histories of Structural Racism and the COVID-19 Pandemic. And it's based on research conducted as part of the COVID Race Inequalities Research Programme at CODE. So this was a large programme of work funded to examine the effect of the COVID-19 pandemic on ethnic and religious minority groups. And one part of the work was our project, which looked at the accumulation of disadvantage over the life course for ethnic minority older people and how they have been affected by the pandemic. So I led this project, and Jenny Hewitt was the research associate who collected the data. And our other team members were Professor James Nasru at the University of Manchester and Dr. Laya Bekaris at the University of Sussex. So I'll very briefly talk about the research project and its results just to set the scene for this webinar. So we interviewed 19 ethnic minority older people aged 61 to 95, and we did this via Zoom or on the telephone, and asked them to tell us their life stories in terms of how racism had impacted their lives. And we found that many people recounted experiences of racism throughout their lives at different key points, including at school, at university, and in the workplace, and in the course of their everyday lives, so at the petrol station or when they're out shopping. And in terms of how the pandemic had affected them, we found that ethnic minority older people had really suffered due to the loss of in-person community spaces where they would usually meet other people and receive social and practical support and advice and information. And we also found that many ethnic minority older people were angry at the discourses around vaccine hesitancy that had been portrayed in the media. So the participants that we spoke to stated that ethnic minority people's views had been misrepresented, So rather than in the media, rather than pointing to historical reasons why ethnic minority older people might not want to have the COVID-19 vaccine, for example, based on previous scientific research, racist scientific research conducted by statutory organisations on ethnic minority people, the participants in our study felt that blame was being put upon ethnic minority people, and as a consequence, they were being portrayed as irresponsible. So I'll just leave it there in terms of the briefing, and I'm sure we'll touch on some of the other things that we came across in the research project as we have our discussion today. So as Matt said, we've got a great panel of speakers here that have joined us to discuss the results of this briefing in relation to the work that they've previously done or that they are doing. Unfortunately, one of our panellists, Tracy Bignall, who's the Senior Policy and Practice Officer at the Race Equality Foundation, can't join us today as she's not well. So we wish Tracy a speedy recovery. And if you wish to know more about the work that the Race Equality Foundation are doing, you can check out their website. And I think one important project that I would like to mention, which I think Tracy would have talked about today, is the Race Equity Collaborative Project that the Race Equality Foundation are undertaking. So this project looked at the impact of COVID-19 on ethnic minority groups in the UK. And as part of this, the foundation commissioned experts in the field to write briefings on the state of the current evidence. And one of these was specifically on ethnic minority older people, which I authored. So I think if you want to have a look at that, you can go to the website and find out a bit more. So we're joined by Dr. Brenda Hyanga. So Brenda is a research fellow in the School of Education and Social Work at the University of Sussex. And she's currently working on a project funded by the Health Foundation, looking at ethnic inequalities in healthcare use with, among people with multiple long-term conditions. And her PhD investigated the effectiveness and suitability of interventions targeted social isolation and loneliness in people from ethnic minority backgrounds. And we're also joined by Shane Ward. Shane's been the Chief Executive of West Bromwich African Caribbean Resource Centre since 1995. He started his career as a volunteer play worker and youth worker in Birmingham. And during the early 1980s, he was a semi-professional footballer and also studied part-time. He's worked in the NHS as a health promotion officer, and he completed his postgraduate diploma and masters in health promotion, researching the significance of the Health of the Nation document on Black men. During this time, he met both Muhammad Ali and Nelson Mandela, and was featured live on BBC Midlands Today to represent the feelings of the community upon Mandela's passing. His recent work, he's a co-author and project organiser for the research report Black COVID and in Lockdown, in Our Own Words, which documents the real views and experiences of Black African diaspora communities in the West Midlands area. So a big welcome to the panellists joining us today, and I'm looking forward to a great discussion. So we are hoping that the audience will participate in the webinar. So please do type your comments and questions in the chat, and I'll keep an eye on this and pose your questions and comments to the panellists. So please do participate using that chat function, as we really want today to be an interactive session. So I'm just going to kick off with a first question for the panellists. So just a very general question to start off with. What has COVID-19 taught us about the inequalities, historical and current, that face older ethnic minority people? So if I go to Shane first.
COVID-19 has taught us a lot about the history and the importance of it. You touched on it in your introduction. When we do our research, when people are talking about vaccine hesitancy, they were coming up with the same points that we were making. There were specific references to the Tuskegee experiment. For those who don't know, it was an experiment which allowed the US government to look at over a long-term period to look at the impact of syphilis. So a number of poor Black sharecroppers were recruited and informed that they were getting treatment, and many had a placebo. It went on from the 1930s up until the 1970s. And the reason I emphasise that, because I was alive in the 1970s, so it's in my lifetime. that this experiment is still going on. It's an experiment in inverted commas, because what happened was in 1947, it was found that there was a positive treatment for syphilis. So at that stage, it should have ended, but it was continued. So this type of deception feeds for thinking around many Black African diaspora communities around the relationship with government and the sort of scientific forces that are out there. So for older people in terms of isolation, you have to put it into context. So my mother and father generation, they were part of this sort of early Windrush type movement. So they came to England in their 60s, sorry, in their 1950s, when they were very young. Now, one of the things I always talk about in terms of isolation is that many of them came without the support structure that I have now. My mother is here in the country, so my children have a grandparent and great grandparents. So we never had that structure. So you can imagine coming to the UK as a 19-year-old or 20-year-old, having to fend for yourself. So all the people have had to experience that when they were young, and what brought back is that isolation in terms of, you're at a point where you regularly see your grandchildren or your children come to visit you, and all of a sudden there's a lockdown and you can't go anywhere and they can't come and see you. So it's impacted in their early life and also in the pandemic. What the lockdown brought. So that's how it's impacted really. And the other thing I talk about is the churches, the significant role of the churches for all the Black communities. When the churches are locked down alongside sort of day centres, it's your regular life, where maybe a Sunday or a Saturday or a couple of two days a week at the day centre or 3 days, that was all just taken away from all people. So their social networks where they found camaraderie, comfort, they were sort of just taken away at a one fell swoop. So it was very, very damaging.
Thanks very much for that, Shane. Shane, a couple of participants just saying that your microphone's just breaking up a little bit. So I don't know if you can get a little bit closer. Yeah, if possible, just for the rest of that's great. Thanks very much. So thanks for your insights there. I think two major things that you mentioned there with the kind of experimentation and the loss of church spaces definitely came up in our research, but I think more generally has come up in research with older ethnic minority people. So I think, if Brent, do you want to come in on that question as well and give kind of your experience and research findings?
Okay, I was a victim of the mute button there for a second. Can you hear me okay? All right, perfect. So with COVID-19, it surprised me as to how much it illuminated the existing inequalities that already existed within the older minoritized populations. This is a population, I suppose, when I was coming into investigate it during my PhD, I started out looking at older people from minoritized ethnic groups. They were considered a minority within a minority. There's not a lot of research that had been done on their particular issues, especially when it came to social isolation and loneliness, which I started looking at in 2016. So my research was pre-COVID, but part of the findings that the key findings of my study was that community-based groups, as Shane was indicating, the churches, any grassroots organizations, which people have got shared characteristics, they share interests. These are really key for people who were suffering from isolation and loneliness. They foster a sense of belonging. You get advice and support. You can go there and, some people were very specific. They wanted community groups where they shared an ethnic background, but other people wanted community groups whereby they actually just shared interests and hobbies. And so with COVID-19 coming in and eliminating that and not having the access for it, it then exacerbates the issues further, because these were the groups, the communities where people were going into. They found these as a way for them to, I guess, find a sense of purpose. But more importantly was that these community groups, as we've indicated, I think in the report, it suggests that older minoritized people can go there and seek advice. They go there for support and for information. But in my research, highlighted the fact that older minoritized people were not just passive recipients of these of services for community groups. They actually played a key role. They were actually giving other people services as well. And these community-based groups gave them roles to play. Now with COVID-19 coming along and just removing this, you get like this loss of a role. And losing a role, just like I suppose if you're in retirement, it can lead to isolation and loneliness. You don't have anything to get up for. And part of the reason as to why, I guess, with the social isolation and loneliness can do this is you have got nothing to do, which can lead to a sense of feeling worthless. So I guess with community groups, we need to highlight one, that they are not just a sense of where older minoritized people are going to receive things, they're actually participating. Like Shane, you indicated the people who are going to church, right? The participants that I actually interviewed, they played roles within these churches, you know, going through if they're the ones who are collecting the monies, if they're the ones who are organizing these funds, and for that to be taken away. I'm quite interested in learning how these organizations, some of them kept running, but how did they almost like adapt to enable the people who had these continuing roles to carry on. So that's just, this is just some of the few things that I wanted to highlight. But also, if I can just highlight from the paper, there was this issue about caring responsibilities that was highlighted as part of the key findings in the paper, Dharmi. And the role of older minoritized people in, again, not just being the ones who are being cared for, but also them providing care. So this narrative of dependency, I guess we need to almost like do away with, because then they do also contribute. So yeah.
Cheers, thanks very much both. Just to pick up on a couple of the things that you both talked about. So just going back to what Shane was saying about people mentioning kind of previous experimentation, including the Tuskegee syphilis experiment conducted in the US. So I think not even just for ethnic minority older people, but for ethnic minority people more generally, this lack of distrust that there is in statutory organisations, you know, at the point of healthcare use or whether it be vaccines, you know, this kind of permeates what we see that is happening in my field, particularly in health research. So, for example, you know, there's a big drive at the moment for people to donate genetic material for kind of genetic studies. And a review we've just conducted recently shows that ethnic minority older people will cite the Tuskegee syphilis study there as well to say, actually, no, you know, we know about this previous experimentation, we're not keen. But also kind of acknowledging that if people don't take part in this research experiments, or if people don't get the vaccine, then that is actually detrimental to their own health. So people really stuck between wanting to trust a state institution for their own kind of health needs and health benefits, but feeling very fearful and distrustful of that based on previous racist treatment. So, you know, I think this is something that will affect lots of different types of services that ethnic minority older people may be accessing, and it's not just relevant to the vaccine, I think. So just to pick up on what Brenda was saying about people losing these social roles. So and I think that relates to these caring responsibilities. So we might think of older ethnic minority people as being cared for, but actually older ethnic minority people are doing a lot of the caring. So in our study, we found that some people were doing caring for older relatives, but also for younger relatives as well. And then the COVID-19 pandemic, with the kind of the lack of services that were available, people who were in these double caring roles, who were older people themselves, really suffered, and you know, they weren't able to get mental health services or practical support, and then they were confined to their houses as well. So I wondered if, Brenda, you wanted to say a bit more from your research in terms of, you know, did you find what it was like for people who have these caring responsibilities, and what particular kind of challenges they may face?
Yeah, I'd say that caring responsibilities is actually one of the processes that I identified that placed older minoritized people at risk of isolation and loneliness. In particular for caring responsibilities for women, because the majority of people who stated that they had caring responsibility and these kept them busy were the women. The men, they did do some caring, but perhaps, grandchildren here and there. It wasn't like a core role. However, for the women, they're indicating, yes, we have to help our grandchildren. They've got nobody, so they feel as though they're the only people who can actually get this role done. So I guess it's almost like social pressures as well, that we are the women, and we are going to be able to take care of our grandparents need us, our children need us more, and the grandchildren need us more. However, there was some participants who were caring for their spouses, and this really stuck to me because let's say this woman her husband had dementia, and she didn't trust the respite services to come and relieve her so that she can go out and go through and have a social life, because we do know caring in itself is a risk factor for social isolation and loneliness. So this issue of trust comes back again, because she just felt like, I don't trust them to look after my husband, I'm going to do it alone. And that then puts her in a space of isolation and loneliness. And she does rely on her family members when they can, but they were very aware not to overburden other people. They felt as though it's their responsibility. Nobody else should come and actually look after my husband. It's my duty. But for those who did accept the respite services, they mentioned that it wasn't enough. It was, someone would come in and perhaps just help with personal care, be in 30 minutes in, 30 minutes out, and they stressed that it wasn't enough. But I think this links to the wider issue of, if we look at societal issues of funding of social care services, this then has an impact. We can see how services for older people have been underfunded for years. And so this then has a direct impact on people's experiences. So this is just some of the ways in which the caring roles impacted people and made them feel isolated and loneliness. And even if they're there, they're not enough to be able to give someone a break. 30 minutes wasn't enough for them to go out. So they tend to just then rely on their own, just rely on themselves and do things the way that they know how to do without any help from services.
Thanks a lot for that, Brenda. I just wondered if you wanted to comment, Shane, because the report that you kind of managed and the report that was on Black people in the West Midlands and their experiences of lockdown and isolation. Was there any other kind of major issues that were coming out for that population in the West Midlands in terms of how they coped with the isolation, like the negative effects of the lockdown?
I think at the top scale, we're talking about a husband and wife who, because of the health situation, they may not be living together because one's in a home and one is out. So, for example, if you're a wife going to visit your husband in a home, and then to go to the lockdown, and that husband is used to you being the main support, and now you can't actually even go into the home. That's the isolation at the worst end. I mean, we do make a reference to there was a granddaughter was saying that she believed that, I think we call it hidden victims. She believes that it was the lockdown that led to her grandfather's death because it just gave up. He wouldn't be recorded in the statistics, but if there wasn't the lockdown, he still would be having the communication with his wife, support mechanisms around him. And she strongly felt that, it was a direct response, a direct, result of being locked down. So generally, one of the things we get a lot of older people talk about is the freedom of the bus pass. And, when they're feeling fed up or they can just jump on a bus to go to local places, Derby, Coventry and whatever else, and just have a day out to clear their heads and everything else. And again, being in isolation, being in lockdown, that was all taken away. So even those escape mechanisms, were cut off. In terms of families, some families talked about they had to reduce their caring rota. So, for example, siblings who may have 4 or 5 siblings who take it in turns, so they have a day allocated for going to check up on their parents with the loss, and now have to choose only one person to do that because the risk of too many different people going into the house to bring infections. So there were those sort of challenges that came about. So some children were okay with it and happy to choose, and others had a bit of infighting to say, well, I should be the person who's going to look after mine. So there was lots of big sort of hidden conflicts. I think we call it hidden conflicts that came about out of the research.
Cheers, thanks a lot, Shane. And I think, sorry, we're still struggling to hear you a bit, but we'll see if like maybe Matt can message you to see if he can help you with the audio at all. Yeah. So just to kind of for those who may not have been able to hear Shane, just to say that he was the last thing he was talking about was people having to make difficult decisions about who might be able to visit somebody in a home, because especially if they were like larger families, having to make there was like conflict in terms of decisions made as to who might visit, and elderly couples were particularly isolated if one was in a home and one was living at home, especially because visits were completely off the cards during quite a lot of the pandemic. So I just wanted to pick up just to kind of just comment again on the caring responsibilities. For some people who are older carers in our study, they kind of liken being a carer to an older relative as being in prison, because they were, we were in lockdown anyway, and then to not have someone on the chat mentioned about respite care. I think a lot of respite care was cancelled during the COVID-19 pandemic. So people really did feel that they just, they were trapped. They were trapped within their homes. They were trapped with caring responsibilities, with very little options to kind of go out anywhere. So they could maybe take somebody out in a car, but at the same time, some of them did say that, life, even without, not even in the pandemic, was still very difficult because of the issues that Brenda mentioned about the very limited respite and home care that is available. So they were doing a lot of this care themselves. So going back to something pre-pandemic wouldn't necessarily make it that much better, which just shows highlights one of the inequalities facing ethnic minority older people, I think, and kind of frames this situation in terms of existing inequalities and the challenges that people face more generally, not just because of the pandemic. So I can't see any other questions from the audience, and they've been very quiet. So please do add your questions and comments so that I can answer them, and the panelists can answer them too. So I think we talked a little bit about the distrust that people feel towards some statutory organisations and historical reasons for this. I think one of the things that I've thought about quite a bit, and I'm sure others have as well, is how can that be remedied? What can we do about that? So, this is not a short-term fix, it's not a short-term solution, but I'd like to get the panelists' thoughts on what can be done to see if, these issues, how can we get people to trust statutory organisations more, or if at all? So if I go to Shane first.
Can you hear me better? Can you hear me?
Yeah.
Yeah, okay. I think statutory organisations have to be a lot more open in how they operate for communities to trust them fully. We've talked about Tuskegee, but you could have lots of examples, whether it's NHS, whether it's local authority, housing, the impact of discrimination has hit communities from all of those institutions. So if they want to build up trust, they have to come up with a much more of an open agenda and actually look at themselves. and say, well, you know, what have we been doing wrong, or what can we do, how can we work with you, and be much more open to listening to what we say is that's impacting us. Because I can give you an example. When we were talking about the early days, talking about vaccine hesitancy, one well-established person who was high up in the health field hadn't even heard of the Tuskegee experiment. So it was a surprise to them that this had happened. But people in the Black community had knew about it, and lots of people have made reference to it in our report. So it's understanding our reality. Sometimes they make sort of plans, but the model of saying what the neighbourhood requires doesn't always fit what we know we want. So they have to have a duality, I think, is probably the best way of looking at it, and say, look, these are the priorities in terms of the general population, smoking, alcohol, etc. But when looking at specific communities, you have to look at what's relevant to them. For example, the high rates of prostate cancer in Black men, that's a big issue for us. Things like sickle cell or death in childbirth, there are big issues for Black, African and Caribbean communities that won't necessarily be highlighted if you have a general population approach to public health. So it's looking at the detail, really.
Cheers, thanks for that, Shane. Brenda, do you want to just come in on that as well?
Yeah, I'd echo what Shane's indicated. It's all very important, including the communities as well. And what I'd also want to add is a lot of the research that I'd been looking at prior to the pandemic, this is as I was looking at studies that have been conducted on older people from minoritized ethnic groups, they tend to indicate that data is collected, but then the researchers don't necessarily go back and tell them what the outcome of the findings are. So you can say that people from minoritized ethnic groups will experience it's sort of like fatigue. You're always coming to research us, and we're not seeing where this particular research is going and what impact it has on, has it made an impact to my life, my community? So I guess stressing the importance of going back and showing that this is the research that we did, we collected this data, even if the findings you didn't find anything in particular, if we get negative, if there was nothing to report, at least then go back and indicate there is nothing to report. But just showing this clear thread of the data has been collected and this is the impact that it has and this is how it's going to help your community. So just that extra bit to add to what Shane said.
Can I add? Yeah. One of the things that we talked about in our research was when you say, whether it's the NHS or public health in a local authority, look at where you invest. Look at where you invest your money. Because one of the things that has always happened is that, one of the things that we've found is that there was a feeling that Black organisations or Black-led organisations weren't really invested in. So the organisations that were more likely to close as a result of the pandemic were Black-led organisations in terms of community-based organisations, and the research, there is research that shows that Black-led organisations are less likely to attract sort of large sums of funding from the the various foundations that make grants and payments to charities to run organisations, and they don't invest in the infrastructure of the organisation. So they may invest in terms of projects to run a specific service, but they don't invest in the operating infrastructure of organisations, and that's where there is a bit of a difference.
Yeah, and I think, Shane, that's something that I've been banging on about for a long time, as I'm sure you have, that these small voluntary-led organisations or grassroots organisations, they're surviving on short-term bits of funding. So they can't plan services long-term, they can't hire staff long-term, and they can't even meet the need that they know that is out there in the populations that they're serving. And that was particularly exacerbated during the COVID-19 pandemic in some of the work that we did, where we reviewed the literature, which showed that, that a lot of organisations just didn't have the money to keep going, but they were getting demands for bereavement support, mental health support, food deliveries. So, you know, organisations that wouldn't even do some of these things were taking on this role for their ethnic minority populations, and many of whom were older people, because they were the ones that were isolated without other people to help them. Which again, it just shows, the COVID-19 pandemic has shown how this is a problem, that these grassroots organisations, very important community organisations, do not have appropriate streams of funding. And the COVID-19 pandemic has just laid that completely bare and shown how they provide a vital service, but statutory organisations, statutory funders are not putting the due importance on them, I think. So I would definitely agree with you there, Shane. And I think that answers one of the questions that we had, which Claire's posed to us. Can you say a bit more about what the research found about how COVID put strain on ethnic minority organisations? So that's kind of answered that, I think.
Can I say,
Yeah.
in terms of the added work, we had to source our funding to carry out the research. It wasn't anyone said, well, we were being asked the question by the local authority, what has the impact been on the Black communities? And this was in the early days. So we hadn't done any research about it. So I was only able to answer off the top of my head and think, you know, based on my experience of working in Black communities, this is what I think will happen. But I couldn't say for certain this is what was happening. That's why we decided to do our own research. And the importance of doing our own research in our own words is that we saw our role as being a sort of microphone for the community. So the community could talk about what the real impact is, how it's affecting them as individuals or families, or their view about the communities as a whole, their views about the politics of it all. And so we wanted to make sure that we got those voices heard. And the thing about it is that we've done that off our own back. If we hadn't managed to get the lottery to support our application, we wouldn't have been able to do it to that depth. And I think what happens is the local authorities came to us to say, well, what should we do? What are the issues? But I could turn around and say, well, you don't pay us to do that. You know what I mean? You don't pay us to do that. Now, if they were saying, okay, right, there's a sum of money, we want you to carry out this research, we would have done it. But that offer wasn't forthcoming. We had to go off our own back to get that funding ourselves. And I think that's the sort of lack of investment that I'm sort of talking about. I'm not saying our local authority doesn't support, but it's the infrastructure investment that they don't get to.
Yeah, exactly. And if they want all that expertise and knowledge that you have, then you should be paid for that. And then that in turn should affect the people that you're working with positively, so, to do some good. I think Claire, Ambition for Ageing, has also said that a lot of the people in the ethnic minority-led organisations were under pressure because staff themselves were facing some of the same issues as the people that they were helping. And I think this is something that's happened in the voluntary sector, but also in the NHS. So some of the research we've done has shown that, the staff in the NHS, they were dealing with bereavement, they were dealing with, working without PPE and lots of other things. So I think, that is another issue that's probably not been researched that much, actually, as to kind of working in the sector and, dealing with those issues yourself as well. But I know, we do have it's a very large study, UK Reach, which is a study of over 20,000 healthcare workers and how they've been affected by the pandemic. So I think that will definitely shed light as more papers come out of that. Also just wanted to pick up on what Brenda said about people feeling they're over-researched and being used, but then nothing ever comes of it. So when the kind of last year, that is something that we heard over and over again. From voluntary groups, from people themselves saying, well, what's the point? What's the point in me telling you my experience or filling in your survey when there has been research report after research report with recommendations telling people there needs to be a race equality strategy, there needs to be you know, proper funding streams for voluntary organisations, and they're all ignored, and yet we just do more and more research. So I think during like the kind of the peak of the pandemic, maybe last year, this is something that was very common across a lot of people that we spoke to. And I think, I mean, we've had just at the end of last week, the final report of the Race Disparity Unit as to why ethnic minority people have been disproportionately affected by the COVID-19 pandemic. And, you know, I had a read of that. There's no mention of racism in that report. There's no mention of the existing structural inequalities that have given rise to these disproportionate effects. So I think people, you know, people working in the sector, people doing research in this area, ethnic minority people themselves, and maybe particularly older ethnic minority people who've seen this for a longer period of time, are just thinking, well, you know, it's really not good enough. And I don't know, there is a sense of despair, I think, from people. But it will be interesting to see how the Office of Health Improvements and Disparities will pick up on the research that we're doing as academics or in the voluntary sector, and how much importance they will give to it. But I think sometimes it is a bit difficult to see how the research will be taken on board by people. So I think there was just...
Oh, Dharmi, can I just add something
to
sure. What you just said about that research? So with my PhD, I was quite aware of this issue of, you know, the studies that are just keen on identifying inequalities. So you're just keeping on saying that, you know, these are inequalities without actually stating how you're going to address it. And it was almost like a mission that I had to, as a researcher, to be able to make my findings evident in terms of, yes, I've identified that there are ethnic inequalities in social isolation and loneliness, but also go a step further and give tips and recommendations. So you're almost having to do extra work to tell them that this is what you need to be doing to be able to address these inequalities, and laying them out and making sure that your findings are going to be easily picked up by policymakers. So it's almost as though that as researchers who are looking into ethnic inequalities in healthcare amongst, you know, people from minoritized ethnic groups, for you to be able to make your research seen, then it needs to actually be doing more than just identifying things. You have to go one step further and show them, this is how I want to implement, this is how it can be implemented, and this is how it can be useful for the people from minoritized ethnic groups. So I guess moving beyond identification towards actually doing something about it.
Yeah, and I think that is something that researchers are getting better at, that, you know, we try to identify who should be doing it and in what way. But, you know, if I'm being a bit resistant to this, you know, that's not actually our jobs. Our jobs is not to kind of make the policies and tell people what they should be doing. It's saying, look, this is the evidence on which you should base your policy making. But I think we are doing that more as academics, because we ourselves are frustrated that the research is not translating into practice. We just had one other question from one of our audience members. So Claire has talked about, asked if the research also found examples of where vaccine messaging was done well or targeted appropriately. So I'll just speak briefly in terms of what we found in our research. So most of the people who took part in our study had been vaccinated, or they said they would get the vaccine, but they talked a lot about other people that they knew that wouldn't get it based on what they knew of previous racist research and previous poor treatment from health services. So actually in our study, people were happy to get the vaccine or already had been vaccinated. So this is not this is not something that all older ethnic minority people think, not by far. So this is just something that they knew about with the people that they spoke to, which, you know, some of them said, you know, well, they should get it, but they were understanding of why people might not want to get it. But they didn't relate this to appropriate vaccine messaging directly, but it may well have been related to some kind of targeted vaccine messaging, but we don't know that from our research. So Shane, do you want to come in on that?
Yeah, we slightly changed the question that was asked, where you know where they talked about 72% of Black Caribbeans were vaccine hesitant. We looked at the question, and that question was a either or. So when we posed that question in our research, we had an undecided category, but we still found that there was a consistently high level of vaccine hesitancy across the board, including older people. But some of the reasons why there was hesitancy was because within the families, you had some who were saying, yes, take the vaccine, and someone was saying, no, don't take the vaccine. So they were not just looking at it from an individual point of view, they're looking at it from a family point of view. But we also did a follow-up question a couple of months later after the research to ask if there'd been any change in attitude in terms of people's vaccine hesitancy status. And the biggest change, there was a change, because we found that the follow-up was about just under half of the original sample. And then we found that for those who had changed, most of them had changed from being vaccine hesitant to now deciding to take the vaccine, or had already taken a vaccine. So there was, I think, what's the importance of the messaging is that it's not all static, it's a fluid movement. So your thoughts at one stage, at the early stages of the lockdown and the pandemic, may be different to later on. And I think there was a lot of messaging going on. But when we found out, when we asked the question, what has been the reasons for you to change? Most of it was to do with knowing other people who had taken the vaccine. It was I think there was only one mention of the sort of public campaigns, you know, the sort of Lenny Henry campaigns that were going. There's only one reference to that as a reason why someone changed. It was all about, I know someone who's taking it, or my brother's taking it, or my sister's taking it, or whatever else. So people were, I think the hesitancy was much more about a wait and see. And a lot of the hesitancy was around because of the speed of the development of this vaccine, which people weren't used to. And I think we were saying was that the message, what the governments and the scientific community weren't getting across, was the high level of open exchange of ideas, information and knowledge. And also they didn't build on the knowledge that they generated from other sort of things like SARS and stuff like that. That message wasn't getting across to the public. So the public were thinking, oh, it's just they've had this virus, and all of a sudden they've got it. And we know that it takes 5 years to get, it passed. So I'm not taking that vaccine. So that was some of the issues, the attitudes that were coming across. But as I said, the biggest change really was that people knowing other people who had taken the vaccine. That was the biggest influence on change.
I think that's where it's important as well to point out that some of the reasons for vaccine hesitancy are exactly the same across ethnic groups. So, it's not that, so obviously there is the issue of distrust and kind of previous historical scientific racist experiments, but that some of the reasons are exactly the same across ethnic groups. So that kind of thought process of this is a new vaccine, I'm not so sure, that would have been universal across people who were not sure. And I think that's what's been missing as well from the whole discourse and debate around vaccine hesitancy. There's nothing about well, actually some people are just not sure. And I'm not saying that the issues around kind of distrust and racism shouldn't be kind of highlighted, but if only those are highlighted, it does make out, as I said before, that the blame does get put on ethnic minority people as kind of being irresponsible for not wanting to do it, and kind of as if they're being quite unreasonable in their thoughts. and not contributing to the effort against COVID-19. So yeah, so thanks for pointing that out, Shane. There was just one question from one of our panelists, who, Samantha, you know, she said that a lot of our research has taken place in urban areas, and whether any of us have done work in more rural areas to see how people had been affected and in terms of their social networks and how they were able to get support. So do either of you have any kind of examples or work that you've done in rural areas?
I can safely say that no, I don't have any work that I've done in rural areas, but as part of my research, I did this analysis that looked at where older people from minoritized ethnic groups lived, and it was 99% of them living in urban areas. So although they are going to be like a percentage of people who are living in rural areas, I wasn't able to access that particular population, but I know that the majority of the people that I was looking at in the survey were living in urban areas. So Shane, have you done any work in that area?
The majority is urban areas. We had a small number who were in places like Leamington and Staffordshire, which are semi-rural. But the numbers of participants were very, very small. I mean, the majority were Sandwell and Birmingham residents.
Yeah, in our research study, it was kind of UK-wide, but I can't remember off the top of my head the exact location of all the participants. A lot of them were in cities, but there may have been some in smaller kind of towns. But again, I don't think any of them could be said to be rural as such. And I know there has been kind of some, you know, even been some news reports about, you know, the hidden problem of rural racism. That, you know, this is something that's not really talked about much or not thought about much in research or even in policy. So maybe that is something that does, especially for older people who may, you know, as part of being in a rural area and being an older person, there could be kind of more challenges there. So I can't see any more questions from our audience. Thanks very much to all the questions that have come through so far. I just want to move the, we've just got one question there from Sean, which I'll take now actually, and then I'll go on to what I was going to say. So Sean's saying, how is this government's recent failure to act on the outcome of research into racism contributed to the initial vaccine hesitancy? So yeah, so how has the government's behaviour contributed to the vaccine hesitancy? So if we just make a brief comment on that, Shane, sorry.
Yeah, I mean, in our research, there were people who made reference to the behaviours of the Dominic Cummings and Dominic Cummings was the main one, where people said, well, look, you know, they're telling us what to do, but they're not doing what they're telling us to do, so why should we bother? And I think that was cited as a reason why not to take too much notice of what the government was you know, telling people to do. I mean, the other thing is people say, well, you know, if they pass the law and, you know, pass the law on whether it's wearing masks or whatever else, then that's a different matter. But if they're just telling us to do it and they're not doing it themselves, then, you know, there's no point.
I'm just trying to, I know my research I didn't look at vaccine, because this is like vaccine hesitancy, and this is prior to that. But I guess it speaks to this issue of research and being done and it being ignored and nothing happening and nothing coming from it. With the research that I was looking at, it's just a topic that wasn't in the radar. Let's say, for instance, with social isolation and loneliness in 2018, the government released this strategy for tackling social isolation and loneliness. And they didn't take a view that they were focusing on older people. They were just focusing on loneliness in general, because it's not just older minoritized people or older people who suffer from loneliness and isolation, but also younger people do suffer from that. So with this report that came out, it was almost as though, oh, you know, isolation and loneliness in older people has been done. Let's move on. There's, younger people also to look at, but using different lenses, we're able to identify that, hang on, older people are not this monolith, right? And so we need to focus on older minoritized people, because then if you ignore them, then, the inequalities keep on being exacerbated. So in terms of the government ignoring older minoritized people, then I felt as though it was, I had this task to be able to eliminate the issues that older minoritized people were facing, and not give up, and not just indicate that, even though nothing's going to be done, something is going to be done. You can even come up with a way to ensure that it is on the policy agenda, that you do bring it up, and not just feel that I'm going to give up and nothing's going to be done, so there's no need to go on. Somebody will pick it up at one point, so the fight must continue.
Yeah, that's like a good bit of positivity there from Brenda, I think, from in opposition to my pessimism. So sorry, Shane, go on.
What I was going to say is one of the things we as an organisation were able to do was which is a positive thing, was to sit down with the contract holders in the health service and local authority and say, look, we can propose to do something else, because the hospitals were locked down. Our staff who go onto the wards and support weren't able to do that. So what we did was, well, okay, let's think of what do we think the community need, vulnerable people in the community on a practical level. And so we sort of created a sort of a befriending service, telephone befriending support with things like shopping, prescription collection, stuff like that, some practical stuff that was very useful and well received by the people, people during the lockdown period. So, I mean, as going forward, we would want to continue that. We have continued it so far, but now that the hospitals are opening back, our staff will be going back onto the wards. But we don't want to lose that service, because it was a practical service. It was well received and it was effective. So that's a positive thing, I suppose, that's come out of it. I mean, we used to do befriending before, but when they started prioritising personal care, daycare, and then the last thing was community befriending service, so that sort of got funding for that was no longer seen as a priority. But I think what's happened in the lockdown, it's shown its effectiveness. Can I just answer a question? There was a question which was asked about research and our sampling. As from the start, we didn't portray it as an academic piece of research, but it did generate primary data. What we did was we worked with organisations that we had good connections with, like the African Caribbean Mental Health Foundation, the Oscar Sandwell, and some other organisations, church-based organisations. So what we did was we got some reach into the community. We were working with people who already had reach into the community. So what we did was we sort of paid these organisations to do some interviews and some focus groups. We carried out some training for those who would be doing it. So we wanted to make sure that it wasn't just research for research's sake. The organisations that were supporting would get something out of it as well. So obviously they got research skills, and they're credited in the report. So and we also made a payment for those organisations for doing it. So they benefited in that way. So it wasn't to sort of it wasn't random sampling. It was just basically using our connections to get the numbers. So we had about 119 people interviewed altogether, which is not bad.
Yeah, and I think that's a really great model of doing research, Shane, and one that we're kind of trying to do in some of our research projects as well. So, with the we've run a large survey called the Evidence for Equality National Survey, which has surveyed thousands of ethnic and religious minority people to ask them how the COVID-19 pandemic has affected them. And we followed a similar strategy to you. We partnered with 13 large organisations that had reach into the communities that we wanted to get into, and so that the survey would be endorsed by those big organisations to say, yeah, this is a bona fide research survey. We think you should take part in it. We think it's going to do some good. And also the model of kind of researching, kind of training people to research in their own communities is something that I think we're seeing more in academia as well. So, you know, there's one project I've worked on where we've trained people who have severe mental illness from ethnic minority groups, and they've gone out and done research with other ethnic minority people with severe mental illness, and they've brought their own experiences to analyse the data and help us to write up the findings as well, so that, you know, we're not missing out on people's experiences. And I think, you know, we've tried to do this for older groups as well, to bring in older people into our research to make sure it's not just about them, it's for them and involving them. So I think that's an important point to be highlighted in kind of any academic research that takes place with people who've, you know, maybe distrustful of academics as well as statutory organisations. I just wanted to move the conversation in a slightly different direction just for the kind of the last half an hour, is to thinking about moving forward, what can be done about ethnic inequalities for older people. So not just in terms of recovering from the pandemic, and we, you know, there are initiatives where we are seeing initiatives such as yours, Shane, where the Befriending service hopefully will stay in place to help people who are still isolated, but also kind of more generally. So we know that these inequalities exist for older people in terms of the health inequalities. They're more likely to have poor health. Ethnic minority older people are more likely to die younger than the white population. So we know that these inequalities exist. COVID-19 pandemic has laid bare some of these. So what can we do, or what should we recommend going forwards for the future? So I'll come to Brenda first, and also to the audience as well. Please put your thoughts on these questions into the chat box, please.
Okay, thanks, Dami. Before, when you were talking about the research that you've done in terms of the training older people and ensuring that the research is not just done to them, but also with them, you talked about the EVEN survey, and I like that particular approach because with the survey, it's set out to collect data from minoritized people and it's data that is relevant, and it's relevant to their life course experiences. So I would urge, if we're going to be conducting research on older people from minoritized ethnic groups, if we can try and include variables that, you know, will capture their lived experiences. I'll give you an example of one of the surveys that I did, one of the analysis that I did using data from Understanding Society. And this was in 2018, around 2017-18. And I'm interested in isolation and loneliness, and Understanding Society has got this huge sample size of people from minoritized ethnic groups. Although older people aren't that much, it is better than other surveys like the English Longitudinal Study of Aging. However, it lacked variables like, you know, these that are important, like social isolation and loneliness and such questions. So I was unable to do my analysis based on that. I had to kind of like create these variables that will give me an idea into social isolation and loneliness. They have included the variables, I think, in these upcoming waves. However, it would have been very useful for me at the time that I was doing my research then. So just moving forward, any data that's being collected, collect data that is relevant to the life course experiences, collect data that includes things like discrimination and racism, things that actually matter, and also to include older people from minoritized ethnic groups and find out what's important to them, because many times we assume that we know what their issues are. I will give one last example, as when I was coming into this research for isolation and loneliness in older people from minoritized ethnic groups, from reading the paper, from reading literature around this topic, you kind of like get the sense that, oh my goodness, they're very vulnerable. They are in need of help and assistance. And yes, they are, you know, we've got these inequalities, but in doing that, we miss out the fact that, you know, they've got resilience. They are people in their own right. You know, we can't just look at them as people who are dependent. They have a lot to contribute. And so we can't ignore that aspect as well. So that's what I'll say about that.
Yeah, just to touch on what Brenda's point about the research data sets that we have available. So a lot of the ones that she mentioned, they don't have enough older ethnic minority people in them anyway for us to do proper, robust statistical analysis. And this is something that in our research group we talked about a lot and written about, that if you really take inequalities seriously, you would collect proper data so that we could show what those inequalities are robustly using proper data. So, you know, there is a real need for national data sets. So this is survey data sets, also kind of NHS data sets, any administrative data that governments collect. These need to properly record ethnicity, and they also need to ensure, if they're sampling people, that they've got enough older ethnic minority people in them to actually make the results meaningful. So yeah, just to add that into Brenda's point, and I'll go to Shane now.
Yeah, I think in our research, one of the things we do identify is the way that they're not making use of existing structures. For example, in the Black churches, they have a reach to older people, and if they were engaged in, you know, properly engaged, they could do their, you know, they could support various pieces of research, particularly around older people. It's not that there isn't anything there. It's just they're not working in partnership with organisations that can give that reach. And I think what you know, whether it's academic institutions, local authorities, or NHS, they need to recognise that what groups like, you know, Black-led groups bring to the table and value it. You know, and as I said, our research was much more about trying to make sure that other organisations benefited, had skills, once they participated in, had skills where they could go out and do their own research. And that's how you empower organisations to do it. And I think sometimes they're a bit scared because of what we may come up with. The benefits of being a independent Black-led organisations, you can say what you want. You know, if the people have told us this, that's what we're going to tell you. This is what the people are saying, and it's not there's no political aspect or angle to it. It's you know, it's not quite verbatim, but it's what, you know, these 119 people have told us. Look, they don't trust this, or they want this, or they haven't got this, and this, you know, the idea about things like guinea pigs and all that type of stuff. It's nothing that's been made up. It's what people are actually saying. So that's the reality. So what we're able to do is bring academics and other institutions back to the realities of what people on the ground are saying, and that is what's needed to be valued. I mean, yeah, I'll leave it as there.
Yeah, that's great. Thanks a lot for that, Shane. I think one thing that we didn't touch upon, which we did talk about in the briefing actually, was the digital divide. So, you know, in our research, we found that a lot of older ethnic minority people either didn't have digital devices, or as well, they weren't comfortable with using Zoom or WhatsApp calls, or some were, especially maybe those towards the younger end of the spectrum of what we're terming as older ethnic minority people. And then the fact that everything went online, so, you know, you've got to book a COVID test online, or you've got to fill this form in online, they were really very excluded from doing those things. They had to rely on people to do it for them, or they just found they just couldn't do what they needed to do. So I just wanted to kind of, did that come up in your research, Shane, in the West Midlands?
Yeah, the idea of having church services online was, you know, some churches did it. The take up of older people was questionable, because, you know, the digital world is very new to older people, and, you know, sometimes they say, well, you can't teach an old dog new tricks, that's the term, and some people think, you know, something, I just can't be bothered with it, and they just, you know, as I said, that they became more isolated because they weren't listening to the church service, they weren't going out, and they weren't getting the regular visits from all the members of their family or networks. So it was very difficult, I think. But it was true. They weren't getting to take. They weren't really agreeing with what was going on in terms of the digitalization of COVID.
In my research, the use of digital apps and technology did come up. It was actually one of the processes that protected older minoritized people from isolation and loneliness, if we consider that they might have these geographically dispersed networks. And so, you know, they might need to communicate with members of their family and friends who are outside the country. And so a lot of them were already using things like WhatsApp and Skype. Zoom was nowhere in the radar at that particular time when I was doing my research. However, it wasn't being used as a sole mode of communication. And even the people who were proficient in using it did say that it wasn't enough. They still needed that face-to-face communication, right? So it can't be used as a standalone mode for communicating and to reduce loneliness. And so this then has implications for, you know, when things moved online and everybody has to use Zoom to kind of like communicate, or, you know, other modes of communication. I really sat there and wondered, you know, the people who were indicating that they need to see people smile, they want to see, you know, they want to touch people and things like that. And I guess this is an issue for not just older people, for minoritized ethnic groups, for everyone in general. However, in talking about the services going online, I just wanted to bring this issue up of fragmented services that we have, especially, let's say, your local services are all moving to the online systems. In one of the, I think in the brief that you had, Dharmi, there was a participant who was talking about having to contact people, and then they're being told that this health service is not available, you need to contact someone else. And that links to the current research that I'm doing now on people with multiple long-term conditions. And we know that people from minoritized ethnic groups have got more long-term conditions. And if these services continue to go online, and, you know, you'd spend hours on the lines there waiting for someone, and then to be told that, oh, you know, you have to contact a different person, this is not the right department for you. And having to contact so multiple different departments, it can be very frustrating for people. It can be very frustrating for people who've got like language difficulties, people who do need access. So this move, or this shift of various services moving online, although it is helpful in some cases, we have to kind of like rethink this in the long run for individuals in general.
Yeah, I think that's, yeah, sorry, go on, Shane.
Sorry, I was just going to say on a ground level, I'm thinking, because my mum doesn't have a mobile phone and she doesn't have a computer, so she would not be anywhere near engaged.
Mm-hmm. Mm. And if you consider that for some people, again, just in the research that I did, going out to the post office or to the bank was actually an event. They looked forward to that. You know, you get up and it gives you like something to do. Now, if things are closed and everything does shift to go online, that then leads to you not being able to, it just messes up your day. Some people had that as a strategy, for like a coping mechanism, that they will force themselves to go out to be able to hoping to bump into someone that they knew, you know, do a bit of like window shopping. And so technology wasn't everything, and you can still see that we need this face-to-face interaction. We still need these services that are not remote and that are not online. So yeah.
Yeah, and I think, you know, thinking more long term, if the move is to make things like more digital in the future, you know, there'll be less face-to-face appointments. So, for example, in health services, then some of the research that we did with the Race Equality Foundation, so the briefing that we did with them showed that, you know, there were small pockets of kind of community groups who were actually holding training sessions for people to come along to show them how to use a digital device like an iPad. And people, you know, obviously it differs amongst people, but some people did value that, and they did kind of get to learn some new skills. But if statutory services such as the health service or councils want this to happen, then they need to put on these training sessions, and it needs to be done in a community place that people can get to, that they're comfortable going to. So the suggestion that we had from people participating in the research with the Race Equality Foundation is that you should have some form of community hub where people can go along and be trained in different devices, get to know how to use these things. And, you know, if it's going to be a long-term move, then the government needs to provide these devices as well. If you expect to be able to access services provided by the state, then there needs to be provision for people who don't have these devices. But I think, you know, I think the move to kind of digital health appointments, for example, has been, you know, it's been beneficial in some ways for some people, you know, especially those who can't travel very well. But then for some ethnic minority older people, it's just not worked at all. They don't feel comfortable doing them. They don't feel like this is a proper interaction. The fact of having to show body parts over, you know, over a screen like this is just not something that people are comfortable with. And just to mention that we've just completed a review for the NHS Race and Health Observatory looking at ethnic inequalities in digital access to healthcare, which will be released shortly. And these issues were apparent there as well. So I think, you know, if we are in any form of lockdown in the future, then older ethnic minority people, there should be some kind of plan put in place now, which details how these people who don't have access to digital devices or who are not digitally literate can still ensure that they're getting the services that they need. And I think this is one of the key things that you know, we found with different groups of older people that they've mentioned. So I just want to give the audience a final chance to ask any burning questions that they might have for our panelists, or any comments that they've got just on the research that's been discussed today, or anything from their own kind of experiences that they'd like to put across. I mean, thanks very much for all the questions that have been posed so far, and I know that you know, people have been putting quite a few comments on the chat, agreeing with the need for better data sets, co-produced research, as all of us have mentioned, and also Carly, I think that's how you pronounce your name, Carly, I hope it is, just mentioning, just agreeing that there's a lot of people who haven't got access to digital devices as well. And Sean, who also had a question before, mentioning that one of his friends that runs a carers charity, helping people fill in online forms, you know, which is just the kind of thing that people need at this time. Sorry, Sean, Shane. Sorry.
Yeah, one of the things about digital access that did come up in our research was, it was not with older people, it was to do with children, but there was one, I know that there was one participant who said, well, I've got 3 children, but I've managed to be given one device, so I have to choose which child can log on to their school for their lesson. So you know, it's very deep. It's not just about even necessarily having, it's having enough devices, and also, you know, if you ain't got the internet, then that's another thing.
Yeah, and that's the other thing with the internet, is people have different connectivities. You know, some of people got fast internet, some people have not, and that's usually based on cost as well. So, you know, some older ethnic minority people who may not have as many financial resources may not even be able to get a speed which is of any use, you know, to helping them to get online.
Dari, may I ask, in this study that you did, you said that you interviewed people online on Zoom. Were there some people who didn't have access to the internet and had to get help getting online, or were there any telephone interviews? Because I'm just considering that perhaps then will there be like a follow-up kind of like study to interview people who weren't able to be interviewed, who genuinely did not have access to online to participate in your study. Were there any of those?
Yeah, so I think we did 13 online on Zoom, and then 6 were on the telephone.
Okay.
But I've got to say, the 6 that were on telephone, you couldn't quite get the rapport going as well. Because usually when we do research, we do it face to face so that people can see who you are. They can, you know, see your kind of facial expressions, your bodily cues, you know, so that they were more difficult. We did have to adapt our kind of research interview schedule to try to get people to talk a little bit more on the phone. But obviously we had to do it on the phone because they either couldn't use Zoom or they didn't have access to it. So we tried to make sure that people who didn't have access could just do it off their landline telephone, which is, you know, which at least most people will have. But I think that is an issue as well. Like, if we're talking about services, but you know, if research is going, during the pandemic, most research went online. So undoubtedly, people will not have taken part in research that may otherwise have been able to take part.
Yeah. And we miss their voices and their experiences. It's something to think about.
Yeah. Just got a question from Simeon. Has any research been done in this field in the southeast or in London? So there probably are studies. I can't think of any off the top of my head. I mean, there were definitely people from the southeast of London in our study. Brenda, I see there might have been one or two, maybe in your study too.
Yeah, most of them are from the southeast, actually.
Yeah. So maybe when we kind of send a follow-up email after this webinar, which shows the kind of links to our research reports and publications, Brenda will make sure she puts one of hers in too. So does anyone know, so Claire has put a question, does anyone know research into digital exclusion of older people that looks at whether it's a greater issue for ethnic minority people? Now, I think there's a lack of research in the area that is comparative. So I think there's a lack of research which compares white majority groups with ethnic minority groups at the older ages to see how much of a problem digital exclusion is. So there are some, I mean, I haven't looked at all the research in digital exclusion, so I don't know for sure. But I imagine, knowing the data sets we've got, there will be very little that is comparative quantitatively. There may be some qualitative research projects that do this, but I don't know any of them at the moment. So I think we're kind of coming to an end there. We've covered a lot of ground, a lot of different topics and issues that are affecting ethnic minority older people. And I hope also we've kind of, you know, had the conversation about where to go in the future, kind of what needs to be done. And there is some of that in the briefing as well. So if you haven't had a chance to read the Runnymede briefing that Jenny Hewitt and I authored, please do have a look at that and get in touch if there's anything you want to discuss. As I said, we will send an email after this webinar, just putting links to some of our research for all the panelists, so that you can follow that up yourselves. And please do get in touch with us if you want to ask anything. I'm more than happy to do that, and I'm sure Shane and Brenda will be happy to discuss the work that they've done too. So I'd just like to give a big thank you to Shane and Brenda for being our panelists and bringing all their expertise and insight to this really interesting webinar. And a very big thanks to Matt and Rahini at the Runnymede Trust for organising this and supporting us and supporting me with some technical difficulties. So, and the last thanks goes to our audience. So thank you very much for your really great questions and comments, and I hope that this has been an interesting discussion. Please get in touch with us if you'd like to discuss any further. So I'm going to bring the webinar to a close now, but have a good rest of the day and thanks again.